Good afternoon to all of you, but also good morning and good evening to some of the participants. It is our pleasure to welcome you to this ITM webinar focusing on COVID-19 in Belgium, and more specifically on the question whether COVID-19 is a game changer for a much better health system in Belgium. This webinar is part of the ITM community webinar series on COVID-19. The main aim of this webinar is to share experiences, expertise, and good practices within the ITM community of staff, students, alumni, and global health community. I will now explain some practicalities of this webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. Questions will be moderated, and only a select number of questions can be discussed given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. Questions related to technical issues will be answered by ITM colleague Sarah Rugiers, and we also have ITM colleague Marianne Pirar with us to take care of managing the webinar, the questions. The webinar is being recorded and will be made available afterwards on the ITM YouTube channel, and you will receive the link within one of the emails announcing the next upcoming webinar. The chat is being closed. And now I would like to introduce you to today's moderator, Professor Dr. Bart Kriel. Professor Dr. Bart Kriel is a medical doctor by training and professor at the Public Health Department at the ITM Antwerp and currently director of the MPH course. He has vast experience in the study of health systems and policies in various sub-Saharan African countries, but also in India and of course in Belgium. His principal domains of interest and expertise are twofold: the management of local district health systems in primary healthcare perspective on the one hand, and the design and management of social protection policies in a universal health coverage perspective on the other hand. Bart, please.
Thank you very much, Charlotte, for this nice introduction. Also from my side, good afternoon to all of you. Good evening to the people in Asia. Good morning to some of the participants in Latin America. And thank you very much for joining us. It is my pleasure to introduce the speaker of this webinar, Rieder Ridder. And actually, there's quite a bit to be said on Rie's very rich career. He's a medical doctor by training. He graduated at the university in Ghent in 1976. And the first years after his graduation, he worked as a family doctor in a community health center in the inner city of Ghent. Community center called The Sleep. Actually, if I overview a bit his career, I think this experience as a family physician, as a general practitioner, has been a major source of inspiration for his work in the past and still today. Perhaps quickly a few features, some of the main features of what a community health center is about. Well, first thing is that it is a center that is very much integrated into the community. A second is that it is staffed by a multidisciplinary team. A third feature or characteristic is that it attempts to provide integrated care as well within the health sector as between sectors, as between the health sector and the social welfare sector, for instance, and trying to overcome the silos between these two. And last but not least, a different payment system than what is currently still largely the case at the first line in Belgium. So rather than a fee-for-service remuneration system of GPs, they have opted for a capitation system. And this is going to come back later in his presentation. Rieder Ridder has been, during a number of years, 8-9 years, he has been, after his work in Ghent, he has been an advisor to the Federal Minister of Social Affairs a big name in Belgian politics. Frank van den Broeke, a social democrat, was at that time Minister of Social Affairs, and one of the I think we can say one of the most influential ministers in terms of policies and in terms of transformative policies. Later, Rie de Ridder joined the RIGIF, INAMI in French. In English, we would say National Institute for Health and Disability Insurance. And there he was the, let's say, the top civil servant looking at the health branch. He has been doing this for 12 years until 2018, when he retired. And in that position, of course, Rie had the great opportunity to really keep the finger at the pulse of the Belgian health system. There are not many people in this country that are so familiar with the nitty-gritties and the complexities of our health system, and in addition with the historical perspective. Rie is now retired, but he's not only sitting in his chair back home reading newspapers, he's also still very active. He's currently the director of the NGO Doctors for the Wereld, Médecins du Monde, Doctors for the World, which is a health NGO and very active in, amongst others, in Belgium, but also overseas. And in Belgium, with particular attention for, yes, people that are under the radar of our social health insurance scheme, like, for instance, people without papers. He could perhaps come back to that later. Rie recently, a couple of months ago, has written a book, a very interesting book. The Dutch name is Goed Ziek. Goed Ziek. It's not obvious to translate this in English. My poor attempt would be quite ill. I think I found this an impressive book, basically structured around 3 parts. The first part is a systematic and a systemic analysis, diagnosis, if you want, of the Belgian health system with its strengths, but also its weaknesses. The second part is about solutions. What can be done to overcome these weaknesses without losing the strengths? And the third part, and I find this the most interesting, and I found this the most exciting part, is a reflection on how to implement these changes, how to change. And there he refers to other disciplines, management, anthropology, etc. And eventually the book ends with a very, very original chapter where 10 leading ladies in the Belgian health and welfare scene take the floor and comment, sometimes critique, sometimes applaud some of the issues that Rie has been putting forward. I should say to all of you, it's a must read, and I know Rie told me that the French version is going to be prepared. Good. Now, why this webinar? Why this webinar? Well, initially we invited Rie the first half of March precisely to talk about this book. And the first half of March, you may remember, well, COVID somehow appeared in our press, but it was still something very far from our bed, if I can say. And but we had to cancel it precisely because of COVID. And so we said we postpone it, and this is the occasion today to have Rie again. He is going to do this in English, this webinar, and actually it serves 2 purposes. A first purpose is precisely to share his critical analysis of the Belgian health system. And you may wonder, also perhaps our people overseas who are attending this webinar, why talk about the Belgian health system at ITM? ITM's mission is to focus mainly at low and middle income countries. What is the relevance of it? Well, I see at least 3 reasons for this. The first thing is the mere fact that many of us are Belgian citizens or collaborators living in and working in Belgium, and so confronted in one way or the other during their lives with our health system. So this seminar may foster, let's say, a critical citizenship. A second reason is that at ITM also we have a clinical department, and within the clinical department, lots of service delivery vis-a-vis Belgian patients. And so for them, it's very relevant. And last but not least, we are also academics, and we wish to study and to compare health systems in different contexts and try to learn from it. The second purpose of these webinar is to discuss now the COVID-19 crisis, which is really a stress test for our system, which puts forward, which highlights some of the strong points in our, puts them in the picture, but at the same time makes also emerge very painfully sometimes the weaker points in our system. And so the idea is really to have a discussion on, and Rie will feed that discussion, what are the lessons to be learned? And I formulate the hypothesis that these lessons are perhaps more universal than we think at first glance. Rie insisted very much when preparing this seminar that this thinking needs to be pursued. The exercise is not finished, and you are invited to participate in this endeavor now, but also in the future, and to exchange on a one-to-one basis with Rie. Actually, Rie, when thinking of these two purposes, the thought came to my mind, this is a bit tricky actually. This is a bit tricky, your subject, because on the one hand, you're going to be quite critical vis-à-vis the Belgian health system. But on the other hand, if we look at the public opinion in this country, they are very impressed, they're very enthusiastic about the system, about the response of our health system. People come in the streets and clap in their hands every night, every evening at 8 p.m. So you'll have somehow to manage, well, this critical analysis with the fact that currently in the perception of the public opinion, well, the Belgian health system is doing very, very well. But I'm sure you'll address this. I'm going to end just to say that this webinar is structured in different parts. The first 20 minutes, Rie is going to present his analysis of the Belgian health system, about 20 minutes or so. And then we'll have a first opportunity for you to raise questions during, let's say, some 10 minutes, not much more. We have to keep track of time, but specifically on this analysis of the Belgian health system. And then we have a second part, which with again, some 20 minutes presentation by Rie, COVID-19 in Belgium, what is there to be learned? Can it be a game changer? And this second part is then followed again by question and answers. We'll take a bit more time there, 20 minutes, because it's an important part. And eventually at the end, a few final words by Rie and myself. We would really want at the very, very, very latest to stop at 4 p.m., perhaps even a bit earlier. Rie, it's my pleasure, please, the floor is yours.
Thank you, Bart, and hello to everyone. I'm impressed by the number of participants, so thank you. Indeed, what I'm going to share with you is thoughts, because I don't have all answers on questions that are being put forward now. So I hope I'm looking to the outcome of the webinar from my side also, and on future exchanges. As you have also international alumni in Institute, I would like to repeat something about the Belgian health system. I will give some strengths and weaknesses, and then explain how my opinion is about what could be a way for the future, and that's a bit what has been explained in the book. Then I will switch in the second part to COVID-19 and how the health system responded to it, and will be continuing with the questions about will it be a game changer, yes or no? And that's, I think it's an important question. I see that there is many discussions starting now about in all public domains about will be post-COVID be the same as before, back to business as usual, or is it an opportunity to have some kind of a new world? This is for me also a very important question, but the background is a bit that I've been working on a more general approach. Can we change the Belgian health system to something which I called a much better system, which is quite ambitious and a bit maybe over-courageous on the one side, and then we get this COVID-19 and sudden completely other context in which we are, where I do have the questions, yeah, what do we have to do now, and what is going to happen next, and what about all these ideas that we had about how the health system should move. So what I would like to bring in. Rapidly, one, how is the Belgian health system constructed? In some sense, it's double-sided. On the one hand, we do have a public health policy sector, and sometimes impression is that people are not aware that we do have quite a lot, a complex system of many institutions, agencies, in which there is surveillance, in which expertise is brought together, in which rules are being set for guaranteeing quality, where there is inspection, etc., etc. At different levels, at the federal level, for instance, in the federal public service, but also at regional level, which more geographical or according to language groups called communities, where again we do have ministries, where again we do have agencies, but other actors which are also very important, like the education system. And one of the things which came now completely to attention again, for instance, with our 11 million inhabitants, we have the luxury of having 9 ministers only for public health, which is complex, which needs political adjustments that is done in the Interministerial Conference on Health. Normally, it's a body which takes decisions, in fact, which makes agreements between all these ministers, commitments, for instance, to adjust policies, the one between the others. And it's normally gathering at something like 4 meetings a year. And now it's almost gathering weekly because of the crisis. So, which means that we have a complex system in which quite a lot of things also can go abroad. There is also advantages. For instance, if you look at the regional authorities, most of the ministers do have a shared competence on health, welfare, family issues, which is an important asset at that level because there is a close link between well-being and health. At the other hand, and that is the complexity for Belgium, is that there are quite a lot of overlaps in the system. But the most important element is that besides this public health policy institutions, we also have another player, which is the Belgian healthcare system, in which the main player is the healthcare insurance. The healthcare insurance located at the Social Security, so not at the Ministry of Public Health, although, and this is certainly a point since, let's say, more than 10 years, that we have one minister who is overlooking both the health insurance and the federal public system. I have explained, so the public health system. Then I explained, then I came to the healthcare system, as it is governed essentially by the healthcare insurance, because most of the money goes through the healthcare insurance for paying for services. It's a compulsory system. It's a reimbursement system. So you make the costs and then the system will pay back based on negotiated fees, which are not necessarily binding to everyone. And it's not completely compensating. So we do have co-payments and out-of-pockets in the system. It's about altogether on the global expenditure, it's about 22%. It's rather important. The healthcare insurance at the federal level, we have more and more at regional level also such systems, insurance-based, which are called long-term care coverages, but they are paying by in-kind services, by cash payments, but more and more also by personal budgets, which are following the injuries. We do have private complementary schemes, which are not that much extended in our country, but that's the third system of paying for services. Now, if we have a global overview of the system, of the healthcare system for the services, it's essentially now a mostly private system of healthcare delivery. It's done to either by private not-for-profit organizations, sometimes by mixed private-public services. We have still some public services, but they have diminished in number and importance. And at the other hand, also quite a lot of self-employed providers, for instance, doctors, pharmacists, nurses also, which are working on the basis of independent medical practices, which means a lot of fragmentation. Patients do have a free choice of providers, so there's no explicit gatekeeping mechanism in the system. And it's still, and this is already the case for over 50 years, predominantly a fee for service payment. And important is that for hospital care, so in hospital care, the medical service are also essentially paid for by a fee for service payment system. These characteristics make that our system is to a high extent supply driven. There are reforms going on, trying to get more to demand or need finance basis, like bundled payments, like the DRG systems, but these reforms are going slowly and not yet pertaining to, let's say, the overall extent of medical services. For the long-term social care, which was also historically very supply-driven, also there are now attempts to come to something like more demand-driven. For instance, by the idea of personal budgets. I must say I'm not very fond about personal budgets because it's the idea of people moving around on markets and buying for the most interesting services, but it's not working that way in practice. Surely, if you have high frail people, for instance, who are impacted by these budgets. So that's the services. It has a number of strengths. One of the strengths is that population is very satisfied by the system. There is also a high level of trust in the system by most of the people, and it's a strength, but it's sometimes also a difficulty if most of the people are very satisfied about the system. Maybe those who are not satisfied are a minority, and maybe there can be quite good reasons maybe to change the system, and then you have a problem of population support. I think the strong aspect of the Belgian health system is that it is not a two-tier system. It's not that you have a public system and next to that a private system which is then collecting all, who is doing much better than the public system, who is much less overcharge, etc. That's not the case in Belgium. We do have all our providers are working through this compulsory health insurance system. It's in some sense the private has been integrated into the public system. For the people, access to most services is relatively easy. We do have waiting lists in some sectors, but you can walk into the hospital without any problem. And we could also say that the system is good, performing well in acute care, when saving lives. And in the actual context, maybe it's a bit difficult to say that because we lost quite a lot of lives. But this, indeed, as Bart explained, there is at this stage an enormous sympathy with the healthcare system, with the people working in the healthcare going on. So everyone is rather convinced that we are very lucky to have this system to overcome the COVID crisis. I identified there are a number of weaknesses, although we have not a 100% coverage. And in fact, as we look to Western Europe and we compare, we have 98.7% of the population covered by the system, but not 100%. And this is the lowest in Western Europe. And I got the remark that if you look at it from a more global perspective, it's still a very, very good number. Although I would say if if our neighbors are able to give 100% coverage, we should also have that ambition. This is about 130,000 people who are known. In fact, the reality is still more worse because we also have population beings in Belgium which are not known, which are not taken into the statistics. And so altogether, our guess is that about 250,000 people in Belgium are not really covered by a complete universal health coverage. There are a lot of gaps. We have mental health, oral health, for instance, only half of the services are covered by the insurance. Prevention, we are lagging behind. We are at least 1% GDP below what should be done. And we are more and more also having underserved areas, for instance, for Medicare, where there is a lack of providers to cover the people. We have a problem of inequity and having access to care. I will come back immediately to that. We have surely overproduction, quite a lot of overproduction, especially in secondary care, with many duplications, many services being done which not really do add any value for health. I mentioned already fragmentation. Fragmentation is going very far because we do still have many mono-professional and even solo practices serving people without very well being collaborating or exchanging information or integrated in their care. There is a gap between social care and healthcare. It's also institutionally, but there are no real mechanisms of bringing together well-being and health in the same package. We have the overlays of fee for service, so paying for each individual service. Just to illustrate, we have a list of possible services of around 8,000 different items, which describe the types of services that can be invoiced to the system. And we have these out-of-pockets I mentioned already. And just to illustrate the issue of inequity, which for me is a very important one, this slide, a bit complicated maybe, shows the graphs show differences. The differences are between the most educated and the lowest educated. And the black graphs are representing the results in 2001, so 20 years ago, for women and for men. The one at the left side is showing the life expectation, and at the right side you have the life expectation without disabilities. The second is the most important because in fact it's representing the life expectancy in good health. And so the graph is showing differences in number of life years, which is at the left. And it shows that from 2001 to 2011, both for women and for men, life expectancy, but mostly also life expectancy without limitations, without disabilities, has been growing. So in a period of 10 years, the inequity, the socio-economic inequity pertaining to health has been growing. And that's not everywhere the case. This is a finding for Belgium, which is, I think, not enough being known, but which is, I find it really a challenge for seeing growing these differences. It's not already that bad as, for instance, in the United States, where we know that now life expectancy is diminishing. We have still in some kind of progress, both of life expectancy and life expectancy without disability for all groups in society, but we are a bit doubtful about the future. And the next slide is about access to care, where we see again, specifically now for Belgium, we see a broad gap between the lowest income groups and the highest income groups. So the orange one is the first quintile, which are the lowest, the 20% lowest income groups, where we see that 6% of individuals declare having had to postpone their care, which has been which has grown drastically over the last years, and compared to 2013 to 2018, this has been extending, and so you could say we had already a gap after the economic crisis, but this gap has been continued to grow, and this is not the case in our surrounding surrounding countries. Now, so I did write a book, and indeed it will be published in French by the end of October. And in that book, I examined in the first part 4 questions. So I try to understand if I say that our health system or our health care system is pretty ill or fairly ill, it's a bit confusing message. So I examined according to 4 questions, to what extent healthcare contributes to population health, how do people experience their care, how do professionals experience, can they do their job in a good and sustainable way, and how efficient is healthcare. And for each of these questions, I bring evidence, national evidence that we do have problems. Some I have been mentioning, like these gaps, like the lack in prevention, like the inequity as pertaining to population health. And for the experience of care, there is the fragmentation, very important, and also the fact that we have not a well-developed, let's say, empowerment of people in their care. And this is being voiced clearly through many surveys being done by families who were confronted, for instance, with chronic disease, with complex diseases, that in fact, people are not taking into account according to the entirety of their needs. They are not very well listened to, and healthcare is being experienced as rather being something which is very medicalized and not being responsive to goals, to what is important for people's lives. For the professionals, there are very strong evidence that many professionals are not very well in their feelings. We do have rather extended problems of burnout, of leaving the job, problems of attractiveness. And one of the findings is that a majority of people working in the care does have the feeling that when they, at the evening, when they finish their job, they have the feeling not being able to have serving completely their patients. And then for the efficiency, there is an overall, not only for Belgium, but an overall estimate that about 20% and even more of the health expenditure is in fact being wasted because it's being paid for, it's paying for services that do not any value for the health and the healthcare of the patients. Now, I think we may say for Belgium, and we have some studies done on that, that we surely are in that range of inefficiency. So that means that there is a large scope also for being able to use or to do in a better way, so that we can use this wasted money in another way to create much more value for our patients. Now, these 4 questions are in fact the questions which are met in what we call the quadruple aim. And so when I say that we need that we can ambition a much more performant healthcare system, then is it for me based on this quadruple aim approach, which says that with the money that we're actually spending, it's about 10% of our GDP on health, it is absolutely possible to have a much better outcomes in terms of population health, for instance, on inequity, for instance, on being performant in mental health or being performant in prevention, that we can have much better patient experiences, that we have much better well-felt care teams for, let's say, the same money. The Americans would say for less money. there is the reducing cost. We would rather speak of the same money spent. And when we look, what does that mean? In fact, the main challenge you could say for health systems is this aging, not aging in itself, but the fact that by aging comes also multimorbidity and chronic disease. This is the graph from WHO. I won't explain it, but it just says that multimorbidity will be the main source of activity, of caring activities in society, including the health systems. And so the ambition I'm setting forward, or the solution I stressed in my book, is in fact setting down a much more performant care organization model, which is in fact at 3 levels, which should be at 3 levels. One, being very close to communities, integrated in the communities, where you get some kind of leadership of teams, multidisciplinary teams, who know very well what are the needs in the local communities, who are being, who are taking into their activities what people feel, what they express as their needs. So driven by population needs, driven by people goals, inclusive, which means everyone is on board, no one is left behind in the community, and integrated care. And care, I would like to stress, for me, care, it's not only healthcare as we do understand usually, it's care in a broad sense. It's also encompassing long-term care, it's also encompassing mental care, it's also encompassing social care, because they all together make and create health for people and for communities. This is the level at local community level. I mean, I'm talking about 8,000, 10,000 people where these teams are operating, but they are managed, they're a bit steered by regional care management, which has a high level of operational autonomy. So it means it's according, it's really working based on the observations and the data that are gathered on the level of population. It's that at that level that the quadruple aim results are being, the outcomes are being followed up. And it's at that level that as much as possible budgets are pooled, so that you have one budget being set up for the population, and where the accountability will be done for quadruple aim results. And then you have the global public stewardship, which should be guided by health, by well-being targets, monitored on outcomes on the national level that we can discuss, which is then the best level for that. So I identified that if we want, because this is a quite other concept of how to organize care, and can you turn that? Can you change the system? This is the big issue, which I really have been troubling looking at. There are some conditions for that. You need awareness, a broad shared awareness that there is a burning platform, that there is a challenge of chronic care. You need a vision how to approach. You need leadership to make the change. You need a change management, and it takes time. And that time, that is about something like 12 up to 20 years you need to change a system. And so that was a bit what I was developing in my book. And then we will move to the COVID-19. I stay here at this stage because this is the end of my presentation for the first. I pass over to Bart.
Thank you very much, Rie, for this first part of the webinar, of your presentation, looking critically at the strengths, but also the weaknesses of the Belgian system. Let me open the floor for a number of questions. Good. There is a first one is, well, when you mention, Rie, the Belgian coverage being, I think, 98 point something%. You know, this would be for many of the people in our audience from low and middle income, because it would be a terrible achievement. But indeed, as you say, it's a couple of 100,000 of people. and they are not covered here. They seem to be doing better in our neighboring countries. Who are these people? What are these groups, and what are the reasons why they remain uncovered?
Okay, so the first group is about 100,000 people. These are people who do have, they are on the list of the health insurance, but for some reason they haven't contributed enough or not paid for the health insurance, so they are considered as being no longer insured. And this is a bit remarkable for a system that it's like a car insurance, of course. If you are not paying for your car insurance, you will not be covered. But pertaining to health, which is a fundamental human right, it's a bit remarkable that the system would not be able to collect its money and says, okay, if I don't get your money, you are sanctioned and we are not going to pay for your services. There are other ways to look at that, and I think it's one of the elements. And on a systematic base, we always have some 100,000 people dropping out. And then we have another group from which the number is much more difficult to state. These are people being in the country, being, for instance, undocumented, or having detached from the system. For instance, people living without homes, living in the streets, who are no longer okay with their papers, with their documents. And we estimate that this group it's at least 100,000 people, and probably much more. So that are people who still will have some, it's a very complex system. We have different systems for covering people. If I talk about undocumented migrants, they can access to a system schemes through the OCMW's, which are the social assistance services from the communalities. But we see that only 10 to 20% of the eligible people effectively can use this system, which means quite a lot of people do not have access to this coverage.
Okay, so a number of people indeed are remaining under the radar. I mean, that is quite clear. There's a second and a third question I would like somehow to bundle. That's about this waste of resources. You mentioned 20%. You said in this country, 20% of the scarce resources that we have are not well spent. This is, by the way, also the figure that WHO mentioned in its 2010 report on financing universal health coverage. So where is this how is this spent? Why is this not used? Where does this 20% go to? What is being done with it? In what way is it well spent? Can you elaborate? And linked to that is the question, if you reduce this expenditure, if you reduce this waste, is not going to be at the expense of patient satisfaction? Is it not going to antagonize your healthcare providers? Could you elaborate a little bit in a minute or two on this wasted money?
The 20% I think for a little extent, it's linked to let's say, phenomena like fraud, deliberate misutilization of the system. Most of the waste is much more systemic. It's much more about, for instance, doing services because of medical uncertainty. I'm not sure I give a medicalized response to something which I get. And in a fee-for-service system, there is much more incentive to rather overuse services than saying no if there is no necessity. We see it in medication, for instance. We see antibiotics in Belgium, it's 4 times the level of prescription as compared to the Netherlands. For instance, you see it in elderly homes with a very high degree of over-medicalization, for instance, against anxiousness and etc. But you see it also in hospitalizations which are avoidable, hospitalizations for social reasons. So people taken into hospital with problems, which in fact are social problems, but are not being solved. Many people at high age are living alone in their homes. losing social contacts, are not feeling very well. And this feeling not very well is being translated into a medical question, which it isn't. And so we have quite a lot of hospitalization, which would be avoidable for instance, underfeeding, because no one saw that a person is gradually degraduating in nutrition, for falls that could have been prevented. And then we have the duplication. Duplication, doing the same examination again. The information is available, but it's not being shared. And that's, I think, also an important source of weight.
Okay. Yes.
Always combined with this fee-for-service payment. So
yes.
If you have to decide as a clinician, if you do or do not an examination, if you say no, you're not earning money. If you say yes, you earn money.
So perhaps, Rie, sorry to interrupt you, in 30 seconds, because I have still 2-3 interesting questions before going to part 2. If you rationalize this expenditure, are the healthcare workers not going to protest because you're going to cut in their income? Perhaps even patients may be less satisfied because they may be very happy that lots of examinations are done. So how wouldn't you not expect resistance from some of the key players if you tackle that expenditure, that irrational expenditure?
If you stay in the same system, of course, yes.
Okay.
Because we are going to take, and that's what we see, that for setting down changes, there are some pilots running, for instance, that you get very, very quickly resistance, for instance, from specialists, because they know that if you are doing more rationally. And so the issue is not about making economies, the issue is about, can we replace low value? This is low value. Can we replace it by high value services? And of course, if you bring these services in, for instance, a team context, and that's been shown by the experience of what we call the medical homes. It's a very bad name. It's so the health centers who are working on a capitation basis. It is shown that, for instance, they have much less of expenditure in secondary care because they're taking much more care themselves, and patients are satisfied.
Okay. Rie, two questions that I want to link. The first one, imagine that we would have an inhabitant from Mars coming to Earth and visiting Belgium and hearing here that we have 9 ministers of health for 11 million people. This Martian would say this is a joke. Could you perhaps say a word on why do we have and why do we need 9 ministers? And related to that, there is also a question, well, could you explain a little bit the historical path that has led to this huge complexity of the Belgian health system, complexity and fragmented, as perhaps will also appear from your second part when addressing COVID. So why 9 ministers, and what are some of the main determinants historically in shaping the complexity of our system? Please.
I think in the long history, so we have now the federal system, the health insurance is over 50 years old and didn't fundamentally change over time. It changed, of course, incrementally, but not fundamentally. And more and more, there was the global way in Belgium is centrifugal. We have language communities. So we have a long history of state reforms. The last one was the 6th one, which touched inter alia the healthcare. But what we have essentially is a long history of Belgian compromises, trying to conciliate these centrifugal forces within keeping together, for instance, in a federal social security system. And that move is, you had never some kind of white paper saying what is the best system for it to achieve for the people. No, it was always what can we change to look at that time better political equilibria in Belgium. And it was also always adding to, without an hierarchy of norms, for instance, which is this is the complexity of Belgium. You have many people on the steering wheels and competing interests, but it says also of the underlying system. The underlying system is sometimes set as a no-system system because you have all these independent actors working there and doing, in fact, to some extent how they feel well. And so
Okay.
these reforms are always trying to get some hold on new realities, but not
Okay.
an intellectual free basis, let's say.
Rie, we have to go to part two. I'll still have a last question, and please try to address it in 30 seconds. There's a question coming from Central Africa, from the DRC. You refer to patient satisfaction as one of the strengths of our system. How did you assess this? How was this assessed? How does one assess patient satisfaction? How did it happen in Belgium?
We have regular surveys, for instance, the health survey. We have there are private initiatives of surveying, but these are general surveys. And so let's say that 90% of population is indeed satisfied with the system, because essentially these are the people who are not the most frequent utilization, not those who make the most use of the system. And we know we have also had surveys, but in-depth surveys done, for instance, by the King Baldwin Foundation, who really went in detail. And then you get a quite other story about how people do experience the healthcare system. But this is information coming from surveys. There are now more and more discussions about taking for instance, patient-related outcome measurements, PROMs, as a source of information. But we are not that far in Belgium about this kind of experience. We don't have a real culture in healthcare of asking the question to the patient: what do you feel about your care?
Okay.
What are you
Still another very last one on part one, Rie. A very interesting question looking at the future. What are, according to you, please try to be succinct in your response, the main potential levels to change things and to evolve, to move towards a more integrated care system? What would be, let's say, the 1, 2, 3 main levers, realistic levers that we have to change the system?
I think the most concrete one is the growing unsatisfaction between professionals about what they are doing, and it will be the growing demand for care and the feeling that the care is not delivering according to what was expected. That will be a major driver for asking for change. I see.
So our health workers can become an ally in a process of change. What other levels do you see, Rie?
The question is to what extent people themselves will ask for. There is the money side, of course. This is the growing budgets, which will put pressure. And what are the choices? So it could be that because of financial pressure, more and more measures are being taken, which will unsatisfy the people. But that's a bit difficult. This is a difficult one.
Okay, good. Rie, there are still very many very interesting questions. I would invite these people to interact with you further on the nitty-gritties of the Belgian health system in the days and weeks to come. I propose that we go to part two. We are going to address COVID-19 and how does our system cope with COVID-19? Yes.
Just in the previous one, I said we need time, you need leadership, you need vision, and you need a burning platform to have change happening. Now, we get COVID-19 coming in unprepared societies, for Europe and for the Americas, in which suddenly we get the leadership of, let's say, epidemiology, including its uncertainties, which is now determining, in fact, how politics should respond to the pandemic. Suddenly, we do have the burning platform, and we have public health being prominently there to, in fact, influence all types of politics actually. We see a lot of leadership coming up, not only from these experts and politics, but at many places. We see it in the health sector, we see it in academic sector. all types of initiatives are being taken to respond to this sudden crisis, which is very interesting to see happening. And we see extremely rapid changes occurring in the healthcare system. Yeah, how I do feel what happens. So take my position as someone who has been campaigning for quite a lot of years for having a change in the system, being aware that this will take quite a lot of time, that you have to convince people, that you need long time leadership, and then you get this. And I'm looking at, for instance, the governance. What I see is an enormous rapid scientific mobilization occurring. And many things are happening there, like sharing all types of information, results. So this is working. But what's striking to me, I would like to question this a bit. All has been set forward in a sort of a priori in the political decision making, which says we need to flatten the curve. This is we need to prevent development of the pandemic in our country, as to the extent that it won't create, like we call it, Italian scenarios or the Wuhan scenarios of overcrowded services. This is to some extent taken as the ground to target to realize. And following on that, quite a lot of priority has been put on hospitals. So we had a lack of tests, priority on hospitals, a lack of materials, protection materials, a priority to the hospitals. Now, what I want to say here in the governance is that there is not much debate. There hasn't been much debate. And I think it's some kind of international consensus also about this flattening the curve. You see it also in other countries being used as being the target of this epidemic crisis. But, just to illustrate, this is an official picture of the Belgian government about the governance system during the crisis, which has in the center a National Security Council, which is at the federal level, which encompasses all the regional authorities also. And it is fed in by essentially medical or public health groups, the risk assessment group, which is scientific, risk management group, which is authorities, health authorities, feeding into the National Security Council about which kind of decisions have to be taken. And at the same time, you see also economic assessment going on and experts who are thinking about how to leave, for instance, the lockdown. Now, this is the official scheme. Very soon, no, not so soon. At a certain point, there were task forces being put in for the elderly homes, because awareness was raising that the most of people were dying in these kind of facilities which were not very well equipped. But the real picture actually of the governing system is much more complicated than that. There are many, many working groups. There are regional task forces. There are task forces looking at the mental health of the people. There are task forces looking at the most vulnerable. And so it's much more like a web in which you get more and more problems also of coordination. But the initial one is this, starting from the health perspective, translated into we need to flatten the curve because we have to protect the healthcare system. We can say that up to now, to my feeling, we have seen several successes in the approach. I think one of the striking ones is this resilience that we see in the healthcare system. So the capacity that it can transform itself very rapidly because there is a sudden challenge. When we are talking about changing the system, this capacity is often questioned. Changing systems is very difficult. And here we see it suddenly, the system shows that it is able to transform itself. I think a bit under stress, underlined is the key role that GPs and primary care has been playing in the healthcare system. for instance, separating COVID and non-COVID patient streams. There have been at the point of making the triage, so the first contact with potentially infected patients. We have seen an enormous capacity of rapidly upscaling capacities in wards, in ICUs, for instance, and on stopping non-urgent care, moving to teleconsulting, etc. So it's the resilience of the healthcare system, to me, is something which is very interesting, is a success that you see that maybe we underestimate this capacity to change. And what also was striking, that when I say that one of the big problems in the healthcare system is the fragmentation, well, also that was rapidly being overcome. Like this triage being organized by primary care networks, acting at the entry of the hospital and integrating with the hospital. But also some examples came later, like the outreaching of hospital hygienists to nursing homes, because there was no knowledge, no sufficient knowledge at nursing homes how to organize protection of patients and of personnel. We have seen a lot of reshuffling of tasks. For instance, I'm thinking of physiotherapists who couldn't continue their work because they were in too close contact with the patients, then changing to, for instance, nursing activities. And so we have a quite strict fragmentation also between professionals linked to competences, like it's my professional competence and no one can come in my place. Now, this was again shifting. It's very interesting. I think that the outreaching, which also spontaneously was being launched, going out from the care sector, from the well-being, but also from volunteers to persons at risk, is also something that is a chair. This happens, it just happens because patients are no longer allowed to come to the medical facilities. Well, the care system starts to contact themselves, those who are at risk. Interesting finding, to my opinion. And then, of course, there is this broad solidarity which came up between not only with the carers, but also between citizens. And I would call it that what we have seen, one of the successes, is this power of mutual community support, which is, when confronted with a challenge, occurs in society. But I also have concerns. I have concerns, for instance, about when this crisis, in the management of this crisis, how difficult it was to have a look on the broader care system, not only on the hospitals. The hospitals got a lot of attention, but what happened in the nursing homes, what's happening with people in institutions for disabled people, what's happening with children who are at risk. And so came up, in fact, consequences of existing but not acknowledged understaffing, underfinancing problems in the health system or in the care system, which showed up by the crisis. And take the third bullet immediately also, because it's closely linked. That is that in the management, it seemed very difficult to get attention to the burden, for instance, of containment on families, on children, on single families. For instance, now we do have the issue. There was really a pledge to the authorities to have more attention for children, that children in this crisis are neglected. The same for care continuity, the fact that people with chronic conditions are highly dependent, sometimes highly dependent on supportive services like physiotherapy, like rehabilitation, and all that was suddenly disrupted. And the burden of this disruption is not very well taken into account. And obviously, there is not enough knowledge being present to really estimate that. And of course, there is the burden also on mental health, which only recently got some attention on this management level. Another big concern is about the inequities. The inequities clearly deepened. For instance, in the schools, it was the most vulnerable one, completely detached from school. They were not attainable by distance learning, for instance, and we do not yet know what are the consequences. But we have also the unprotected communities, and as a president of Doctors of the World, we are very close. I think we have some, with Doctors of the World, we are coming in 12 or 13 facilities in Brussels, for instance, where sometimes 100 people, undocumented migrants, homeless people, are staying together very close to each other, so difficult to have the social distancing. And we do have at several places really outbreaks of COVID actually, which was expected. I mean, we knew that that could be happening, but it's only now being documented because we just now started with testing. So unprotected communities are also very, very vulnerable due to the COVID. And finally, one point also I think important is that we see we are now more than 8 weeks ahead in the quarantine, and it's a bit striking to see so little citizen involvement in setting the priorities. And that's one of them also major aspects when I'm talking about another view on how we can have more performant health systems. One of the important aspects is people empowerment, people involvement, community participation. What we see now in the crisis, that this is lacking. Now, the question, and that was a bit the challenge I got, is this COVID crisis really be a game changer then? Is it giving perspective that we will be able to learn from this crisis to adapt the system in the future? So question are these 6 successes that I described, are they transferable to, for instance, to the issue, the challenge of multimorbidity? Will weaknesses be acknowledged? Like, will we find a better balance in priority setting? One of the, for instance, I'm thinking now about risk stratification strategies in care settings. There is the example of the Kaiser Permanente pyramid, which has the ambition to make sure that the resources that you have, the most of the resources you have, are being put on those who are most needing them, both using the capacity within communities to be self-government, self-sufficient, self-relying by, for instance, health promotion, etc. Are we will we be able to learn from this crisis to find better balances in this risk risk prioritization? I have a notion which I call the moral guilt. So we have we put quite a lot. The crisis put an enormous burden on staff working in hospitals, nursing homes, etc. And so one of the outcries now is that surely there should be more investment in the care sector, surely in the nursing homes, more people, although a warning is that the answer, is that the only answer for the health sector after this crisis is only more? Should we invest more money? But it should also, of course, be also how we are going to invest. And then I have a very big concern about these most vulnerable. They will still be more vulnerable. They have been for a long time under the radar, and they will be more vulnerable for the first place because the people who are the most vulnerable are also those who are the most vulnerable in the labor market. And actually all indicators are showing that for these groups in society, they are going for a very long journey of much more unemployment, or much more loss of activity in informal economy without compensating mechanisms like we have for the unemployed, for the technical unemployment, which has safeguarded family incomes for the, let's say, more the middle class. And of course, are we going to learn about institutional complexity, about coordination gaps? Actually, on the political level, some are saying, yes, we have to steer everything, the global stewarding force on the federal level at almost the same moment. Others are saying, no, we have to de-federalize, we have to bring everything, for instance, on a regional level. So these debates, of course, these are coming up. I think the one of investing in healthcare, it's on the table. The one on the coordination, it's on the table. But for the other questions, I don't see yet really the issues. And so things like new experiences that we have had, like this outreaching, like substituting activities between across professional disciplines. New initiatives, schakels ook means facilities to host people who do not need to be in the hospital, but not strong enough to return to home. The integration between the silos, the role of GPs, the role of primary care regions, etc., is a question. And then I'm not going to explain that. The one about Big Pharma, I put it as a question mark because it's too early to really have conclusions on how, on the issue of vaccines and on the issue of medicines, how it will be tackled. Are we going to see the same mechanisms as we've seen with AIDS, etc.? So I have my last slide, Bart.
Yes, I would propose, Rie, that you leave this slide without going, I mean, it's a sort of summary in a way of some of the issues you have addressed, that we keep this for the participants, but that we look a bit into the questions. I have, and the questions are actually, very interesting and also relate to some of the issues you have said. There is one question on the, let's say, the role of experts in the entire decision-making process over the last couple of weeks and months. Yeah. It is clear, I think everybody recognized that the epidemiological expertise, the virological expertise has proven extremely important in order to get to know exactly what is happening and to try to anticipate how this is going to evolve. However, it seems that this sort of monodisciplinary expertise reaches slowly its limits, its limitations. And so there is a question, should there not be more room for a more multidisciplinary approach to expand, for instance, the GEES, yes, the group of experts on the exit strategy to other disciplines, specialists in poverty, education specialists, etc. There has been the debate also a couple of days ago, should the reports of the GEES not be made public? Why is this not accessible on the public? I mean, it's as if something has to be hidden. Could you say a few words on this? And also, that was the final question of that participant. Are we doing there worse than neighboring countries? Are there things to be learned from other countries in that respect, in having a more comprehensive composition of expert committees and also involving people and the public opinion at large? Rie, could you say a few things on that?
Yeah, on the first one, I'm really sharing this concern. I think 8 weeks is a long period. Huh? If you look at the impact on children, on education, we don't know yet very well how on the long run we will have these effects. But the fact, for instance, that the move to distance learning necessitating, for instance, laptops and some kind of skills, and the reality in quite a lot of families who were not able to connect with this virtual media, I think it will leave its consequences. I have very big. So I showed you the differences in healthy life expectancy. I'm really wondering, and I'm afraid that on the long run we will see even a bigger impact on these inequities, and that is a societal question. Mm-hmm. It's only just the last week that the burden on children has been identified by politicians as being an issue. Well, I think this is really worrying. Now, connected with the second question, are we doing worse or not? It has to be assessed later on, I think, seeing who did well. It will be probably a very nuanced question. But let's be clear, we have this crisis with a government which is a minority government, which was which was expected to not exist at this stage. So it's already a problem of leadership. And so there has been experts, or I think there's some common agreement that experts are now a bit used as being the screen behind which politics are hiding for making choices in society. And then I do have a concern that it's essentially virologists, I mean the medical approach, which is playing a role, and not seeing the other aspects, the burden of the measures itself. It's not an easy question. It's not an easy.
Okay, let me just on that particular question perhaps provoke you a little bit, Rie. Saying citizens should be involved and reports should be made open to the public. I mean, that sounds, and I'm intentionally putting it bluntly, that sounds politically very correct. But what in practice do you expect from citizens? How can they impact what is? How do you see this? Is this more than just lip service to something that everybody agrees with? Or would you see this in practice? How can citizens, how can people in such a crisis have their say in the decision-making process?
Well, we have some examples of mobilizing. I think today, at this very moment, the weekly survey of the Antwerp University is running. Every week there is, of course, it's collecting information via the website. So some groups will not be participating to that kind of service, but it's about this kind of taking. In fact, it's about the culture of being open to society. About these are the choices we are before, and that's the way we are making the choices. I think it's counterproductive, more and more counterproductive, not to be as transparent as possible about the choices that are made. Of course, it's not the single citizen. We have seen the civil society has been showing itself very strongly in this crisis. Civil society is in the capacity of making judgments and of having a public debate. The same for parliamentary people. So now it's absent, and leaking information from the report. It's much more something like lobbying for one or another outcome, for one of decision to be taken, and everyone starts to lobby for its own sake, and then you don't get a real judgment between society. There are quite a lot of possibilities. I mentioned working with the King Baudouin Foundation, for instance, for making choices in society. Citizens can do that.
Okay. Many of us, I believe, have seen yesterday on the public television the images of our Prime Minister visiting the Hospital Saint-Pierre in Brussels. And she was not really welcomed. There was there were double lines of health workers turning their back to the Prime Minister. I must say, I must confess, I pitied her a bit, because it has been a very, very tough job. But at the same time, it points to a profound dissatisfaction, frustration of healthcare workers. Now, could you elaborate a little bit? What could be done realistically without this having necessarily to cost huge amounts of money, to better appreciate our health workers? And I'm not only thinking of the specialists, we're thinking of the nurses, the nurse aides, the receptionists, the people running the ambulances, also the smaller jobs in that pyramid of what could we do as a society to better value them, to ease that frustration?
Some part of the answers are already given. I think some elements in debates are not I think the good answer, like there are parties who are saying we have to pay some premium, for instance, to compensate for this this risk taking that we're doing. I think it's much more fundamental what the care sector is asking for, what they call, we want to be recognized. The first thing is in fact, that the care sector for a long time, and maybe not the most in Belgium, I'm now thinking also of countries like UK, for a long time in the political discourse, healthcare is considered as being a cost to society, as not being productive. I think this is something which is clearly an image that has to be turned. One. Second, that means that if people, if care professionals come into the streets to ask for more better careers, for having more people work in the sector, I think that is one of the most important one. If you say, I pay you some money because you have taken risk, that's not a good sign. The good sign is, can we, and I come back to the quadruple aim, the one of the carers being better in their working condition, but it's also the element of preventing that people are doing activities which are not creating value, but which are time consuming, which are giving a high burden, a high stress to the people. So I think it's a combination, and probably there will be some willingness of having more money in the health sector, in the care sector. I hope it will be a good utilization then. But the most important is that people have to be able to determine the conditions in which they are working. What the professionals are saying is, we want to do a good job for the patients, and that should be supported. And so this, I think it's also an element of having much more human resources policies on the people who are working in the care, not only for the professionals. I would also want to mention volunteers. There is an enormous volunteering work going around in the care, and I would also mention the informal care, underestimated, and so having now, for instance, grandparents. The discourse is grandparents should not be caring for the grandchildren. It's so opposite to the reality of transgenerational solidarity that it should be taken more serious, this kind of request from the carers themselves. I think also the Prime Minister for that. I think there was some very unlucky decision being taken, for instance, about requisitioning personnel, while there is no need of having such kind of measure actually. This is really felt like offending the carers.
Rie, I think we have slowly to wrap up. Let me come with a last question, and I'm here a bit, partially at least, the spokesman of Professor Jan de Lepelaar in Leuven, who could not attend, but who sent me a question. As I think most of the people in the audience know, also the people, former alumni, if you look at the architecture of the Belgian health system, you don't have an intermediate sort of body between the macro level, the policy at the national level, and the micro level there where the services are being provided. There is no sort of intermediate structure like we have these in many low and middle income countries. I'm thinking of the districts, whatever their name. Some sort of body that is a cushion between the top-down planning, but it also channels up, bottom-up issues. Now, we have in Flanders, that's a regional, has been a regional development. We have the creation, it's still in an embryonic phase of the first-line care zones, eerste lijn zorg, eerste lijn zones, first-line care zones. The name matters. It does not say first-line healthcare zones, it says first-line care zone. So it's bridging that link between healthcare and welfare. What do you expect from these sort of developments, and perhaps say, it's a hypothetical question, Rie, but if this would have been fully operational, would this have impacted the way how COVID-19 would have been managed in this country?
I would say it's otherwise, but first for Jan de Lepelaar, I invite him to read my book because the answer is in the book also. I believe that the primary care zones are indeed a good basis, and you could compare it to the district concepts. So it's the intermediate level. If I say the care organization is on 3 levels, it's the intermediate one. Okay, the Flemish primary care zones are about 100,000 people. Maybe I find it a bit small, but it's okay. But in the COVID crisis, I think the although just recently being created, they already showed their potential of being at this level of district. I think we have to validate what they have been doing. So I really think that they are an opportunity of being some kind of the framework. And why? Because social care is there, so healthcare is there, social care is there, and local authorities are there. So the local democratic level is there. Only thing which has to be elaborated is the link with the secondary care, with hospitals and secondary care,
yes,
which
indeed.
is at another level. Just mentioned that I was one promoting for pilot projects running actually still. They are running until next year, and they will be assessed, which are also about this intermediate level, looking for how to steer population oriented care integration in the region. But it's indeed, we are lucky to have them. I would say it was a good thing to have them now. It has, I think, the triage centra, there would be more difficulty if they didn't exist.
Yes. Okay. Let me. I think we have to keep it here. Rie, I want to share one or two final thoughts from my side on the discussions. In the very first place, this was very interesting, Rie, and I think we had some excellent questions. Many still are there. We can, before ending later, show your final slide with your email. We can do that later. There's one thing I wanted to say on as a citizen and yes, an observer of what is happening in Belgium, but also an academic, a researcher, a teacher. I think it's interesting to see what will happen when the dust settles a little bit after the most acute phase of COVID-19, and when democracy again enters into well, does what it is supposed to do and raise questions, not in a trial sort of atmosphere, but critically try to pinpoint to the systemic deficiencies and try to address them. And I think that's what we all hope, that in a couple of months from now, we'll have a government, a democratically representative government, and then we can look at what went wrong and learned from that. Concerning the Belgian health system, well, it's clear, Rie, from your presentation, you highlighted the complexity of our system. This has to do with path dependency. We still face consequences of choices and decision taking that have taken place 10, 20, 30, 40, 50 years ago. You cannot change overnight, no big bang. So you still carry that weight. You also pointed to the very important need to have a systems approach. There's not one single magic bullet. It's a number of things to do at the same time. Some of them will work on the short term, others on the more longer term. That it's crucial to look for allies in the change process. I mean, and some of the allies some of the players are extremely important. If you don't have them on board, it makes change more difficult. And finally, perhaps end on a personal note, when I finished university in 1981, the family medicine discipline, the general practice, was almost laughed at still at that time, 40 years ago. I see that a long way has been, and lots of progress has been made in sometimes a bit insidious way, silent way, under the radar, but it's clear that still, if there's quite some work to be done, that the GP profession and the place of the first line has dramatically improved over the 30, 40 last years. Just to give hope to people, change is possible, but it may take time. Okay, I want to give you, Rie, perhaps the occasion for a couple of final thoughts.
Okay. I would just say this is my intellectual activity. I try to find reasons to make COVID a game changer. This is an invitation to you. Look at it. I think in each of the elements, we find in the COVID crisis elements which might be a case for saying we don't want to go back where we come from. We want to come to another reality. Now, I've seen, meanwhile, while you were talking, Bart, I looked at the questions which were still open, and so there were Several questions coming also from the international alumni, very interesting questions. So I hope we find a way to respond to them also, because they are worthwhile to being treated. But I would just finally say, okay, this way webinar, I'm not very fond of the webinar system because I don't see you, dear audience. I can't react to you, but I hope that this webinar is for you also some kind of incentive to participate, or to continue in thinking, elaborating. I'm not saying I have all the knowledge on the questions. It's much more question marks than answers that I can give. But anyway, thank you for having taken the time for listening to me. Thank you.
Okay, thank you very much.